Okay, you're live.
Good afternoon, everybody. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority. I'm joined here today by Dr. Tom Jean and Dr. Ariel Smith for your Tuesday provider webinar on COVID-19. We're glad you could join us again. We've been getting lots of positive feedback about these sessions. We are going to continue these both on Tuesdays and Thursdays through May, and we continue to welcome you to send us information about what topics you'd like to cover. As a reminder, we are not able, due to our system set up on Tuesdays, to receive real-time questions. We build into our content responses to questions we've received in the interim. And we will continue to capture those on your chat box today and through the email, and we'll respond to those through our future meetings. So today, we are going to talk about the following agenda items. We are going to talk about, again, our normal EPI updates and a little bit more about our surveillance strategy moving forward. We will share some more information on the recent news moving towards resuming elective and non-emergent procedures in our state. We'll talk a bit about updates to our hospital visitation policy. We're going to share, just for informational purposes, the IDSA guidelines on PPE as a resource that you may want to have. We'll talk about updates on CDC symptom lists for COVID, and then close with some of the questions that you sent to us before. And actually, before we close, we have some late breaking data from the survey that we asked providers to respond to. We'll share some of that data at the very end of the session together. So first, our epidemiologic update. This data that you're seeing here is as of yesterday. Again, we update this data daily on our website by the middle of the afternoon, so we're always just a little premature to give you the hottest data. But as of yesterday, we had a total of 2,354 positive COVID-19 cases. As always, we remind you that these positive cases based on testing do not reflect the full impact of COVID-19 in our state. There are also, unfortunately, now 92 deaths in our state from COVID-19 as of yesterday. And still a significant portion of our tests are negative. You can see here there are 48,844 tests done to date that were negative. I also brought you this data, which is also posted weekly as one of our weekly updates. It's called our testing summary update. As we talk about the percent positives, this is one of an important monitoring or surveillance tools we have for looking at our data. This gives you a summary of our Oregon test results through the end of last week, and it looks at those weekly. So across the top, you can see weekly counts of positive and negative tests, the total of those tests that were done during that week, and then the percent that were positive. So obviously on the far left-hand side, those were the first couple weeks that we had cases, and I just want to caution you about the percent positive. We were just testing so few patients at that time that is not likely representative. But as you look across the bottom row, you will see that our percent positive has been generally and slowly declining over the last couple weeks. We've maintained a percent positive just at or below 5% total of total testing done so far, but we are actively monitoring any trends in the percent positive as we move into our next phases of COVID-19 in our state. Again, you can find this information and further information about our current testing on our website in our testing update on our webpage. I'm going to pass this to Dr. Jean to give us some more of our epidemiologic update.
Right, so here for those who have been attending these webinars every week, this looks familiar and might be a little boring, but boring is good for this because we're seeing a continued gradual decline in our epi curve in terms of case counts, both hospitalized and non-hospitalized case counts. And this seems to be mirroring what's happening across the US in general, although there certainly are parts of the US that are still increasing or don't look quite as positive as this. So very encouraging, and we're continuing to watch this and keep an eye, especially as things start to reopen in the coming months. This is also very familiar. At this point, we can start to see perhaps a little bit of an uptick in daily ED visits. And anecdotally, that might be just because people are out and about a little more. There's certainly more traffic on the roads and all that, but certainly no major increase. We're still at around 2,500 ED visits daily statewide. And reassuringly, the next slide, our daily visits for COVID-like illness are standing nice and low, just over 1%.
This is Dana. I would just like to use the opportunity here when you're looking at this slide. This is a good reminder to pass on to your patients and friends and colleagues that we still really recommend physical distancing because we are seeing increase in traffic and other movement. We know that people are getting tired of this, and it's really important. We know how successful it has been reducing transmission of COVID-19. We are looking at, the governor's office is looking at how we might slowly phase in some reopening, but at this time it's really important to keep the physical distancing, and I think perhaps the increase in ED visits is a reminder that's still important.
Absolutely. And then this slide is showing, this is from our weekly report, and this is will be released today. This is showing our signs and symptoms for all cases we've received to date, which is over 2,300. And we've arranged this now by prevalence or by the frequency of symptoms, although it's not quite in order, because if you look at the gray bars representing the unknowns, those vary quite a bit. But you can see that when you exclude the unknowns, over 90% of people who tested positive have had any symptoms at all. And then the cough, fever, muscle aches, shortness of breath, and chills are the most common symptoms. But you can see there are quite a few symptoms that are fairly common, including sore throat, nausea, some GI symptoms, headache, and loss of smell, for example.
This is data we've shared with you before. If this is new to you, this is data that is reported to us daily from hospitals as part of our hospital capacity web data monitoring system, or otherwise known as HOSCAP. We've been monitoring this as a really important surveillance tool to understand capacity at our hospitals. On the far right, this is where we're monitoring the patients who are currently hospitalized with a positive COVID test result. So as you can see here, there are a total of 123 patients hospitalized across our state with COVID positive test results, 36 of those in an ICU bed and 24 of those on a ventilator. On the left column, those are patients who either have symptoms of or undergoing testing for COVID plus the positives. So that's kind of your COVID total impact to hospitals right now. That number of total patients is at 247, and you can see the rest of the results that follow. We are working to provide some trend lines in our daily reporting that show you how this capacity has changed over time. We are certainly monitoring that. Just for now, since I don't have those yet, I'll let you know that the total hospitalized with a positive test result, that maximum was about 156, if I recall correctly, and that occurred back on about April 7th. And it's been trending downwards or at times staying static. The current total hospitalized, both positive and suspected, that number maxed out so far at about 464 about that same period. Again, we're trying to get some trend lines publicly reported so you can monitor what that looks like as well on our website.
Okay, I'd like to provide an update on our modeling projections. We had an update that was released on the 23rd, and the takeaways from that are that it's been fairly similar to the previous ones, with just a slight update and adjustment to the numbers. We predict that there have been approximately 8,400 cumulative infections in Oregon, and of those, 1,900 had been diagnosed by April 16th. And the estimate is that the interventions we put in place have already averted over 70,000 infections statewide and over 1,500 hospitalizations. And then, as it has in the past, the projections have included two scenarios, the orange and the blue, which show a return to kind of more lesser interventions and restrictions with a significant rise in cases, and then continuing where we are now, showing a gradual decline. And we're working for future updates for this to mitigate, to model our surveillance strategy, which we'll talk about in a little bit, and how that will mitigate the orange line, reduce that orange line when we do ease some of the restrictions, because we certainly don't want to see cases going in that direction. And the next slide, this is showing hospitalizations, basically. So severe cases that are hospitalized, critical cases in ICU care, and cumulative deaths. So a similar trend here, gradual decline with current interventions. And again, our aggressive active surveillance and containment strategy will try to suppress and make our line look as much like the blue line as possible as we ease social restrictions. So now I'd like to shift gears a little bit and talk about our surveillance strategy. So last week, the Governor's Medical Advisory Panel, which is a panel of physician and public health experts, reviewed and approved our active surveillance strategy that we had developed. And they're still reviewing the parameters for considering stepwise easing of social restrictions. They'll be reviewing that today, and that's going to give us some better indicators for how we'll know when we can continue to ease restrictions, and how we'll know that things are working in terms of active surveillance. So what is active surveillance? Well, it involves staying in regular contact with people who are diagnosed with COVID-19 and their contacts, so that we can isolate and rapidly respond to changes in their health conditions. So that includes expanding testing. It includes identifying and investigating cases, both from testing and then through broad contact tracing of those cases, and then isolating and quarantining as appropriate. And then finally, identifying and quickly intervening to prevent disease transmission among at-risk groups and new clusters of cases. So in terms of our testing, testing is a big part of this, of course. We need testing to know how many cases are out there. And so we've already been broadening our testing guidance. We had the testing guidance update last week that expanded some of the higher risk groups that we would recommend testing. And I'll just throw it in here again, because I keep hearing that there's some confusion that OHA does not restrict or allow testing. We are only a gatekeeper for the state public lab, which is a very small slice of all the testing that's happening in the state right now. And our testing guidance document is intended to be just that, guidance and recommendations for clinicians, while allowing them flexibility and their clinical judgment to decide who should be tested. So again, we broadened our testing guidance. We are working to fully utilize the testing capacity that we have in Oregon, which has been steadily expanding, to make sure that the supply chain supports our state testing needs, to ensure that all individuals that need testing get the results within 2 or 3 days, and then also building additional testing capacity in regions of the state that currently don't have much in-house or local capacity for testing. Other parts of that testing strategy include some overflow testing that will happen at health system labs that have capacity, so kind of trying to distribute some of the load from regions that may not have as much capacity. And then surveillance testing. We're planning to do some testing through our influenza like illness surveillance system. So patients presenting with influenza-like illness or COVID-like illness will get specimens sent from around the state as kind of a sentinel surveillance, and that will give us a sense. And then finally, we're planning a seroprevalence study. I think I mentioned it before, but that will include a sample of people around the state and do serology testing to look for antibodies, and that would include people who never had symptoms. Okay, so just moving on the slide here. So testing is a big part of it, but really the action end of this all comes down to the investigation, the public health work that we know we need to expand. And so one of the big parts of this is our workforce. So we've identified some estimates for what we need in terms of who we can hire and bring on board and train to do case investigation and contact tracing and help out all our local public health experts who are already trained in that. So these could be they could be volunteers, they could be hired, or they could be contracted by state or local health authorities or tribal governments. And we really want to emphasize recruitment of local people, community members, community and traditional health workers, and ensure that the expanded workforce is culturally and linguistically competent. That will help build trust with communities and increase their adherence to our recommendations for isolation and quarantine. So again, there's multiple components here. You got to identify the cases. You have to do contact tracing as soon as you get a test result to try to figure out all the people who that case had been in recent contact with, and then isolate and quarantine. So isolate would be for people who were cases with symptoms. Quarantine would be for contacts who had the exposure but don't have symptoms. And then also important to that is to provide wraparound support. So we really need to make sure that we are supporting people who we're asking to isolate or quarantine. It's going to be a voluntary isolation or quarantine. And so that's the supports that we can do in terms of, whether it's basic things like shelter, nutrition, or support services like mental health and social services. That's going to be so important to make sure everybody is sticking to the recommended isolation quarantine, which in turn helps reduce the spread of COVID-19. So it's a work in progress, but as I said, it's been approved by the MAP, and so I think at this point it's up to the governor's office to make decisions as to when this will be implemented. But we're planning to have. We're already in the stages of hiring and working on the workforce, and so hoping that by the end of May we'll have most of that in place.
Great, thank you, Dr. Jean. And we'll be, as more of this plan and the details come forward, we'll be bringing this back to you along the way to keep you up to date on this very important work moving forward. We're now going to talk about another timely topic, and that is based on the news that was released last Thursday by the governor, stating that she is going to allow resuming of non-emergency and elective procedures requiring PPE in certain cases. So let's just go back one more time historically. About 6 weeks ago, one of the aggressive measures were taken by the governor that were really important at the time to cancel all elective and non-urgent procedures requiring PPE. And this was critical as we were preparing for a potential of COVID-19 cases surging and impacting our hospitals. However, we also know now where we sit looking at the data and cases that further cancellation is perhaps not necessary, and if further delayed, cancellation of some of these procedures, while elective, are truly necessary for Oregonians' health, and further delay could have negative impact. We also know that cancellation of elective procedures has had a significant impact on the financial stability of the healthcare system. So last Thursday, the governor announced her plan for resuming these procedures as early as May 1st, as long as certain criteria are met. So we will walk through where we are with some of those criteria. First of all, again, the medical advisory panel of the governor reviewed and really helped to formulate this framework for which we're using to advance these procedures. And the following 5 priorities were really at the forefront as this framework was being created. So the following priorities really have to inform all of our actions as we move towards resuming non-emergent and elective procedures. So first, to minimize the transmission of this coronavirus to patients, healthcare workers, and others, to avoid further delays in healthcare for Oregonians, to maintain adequate hospital capacity in case of an increase in COVID-19 cases, to minimize transfers to skilled nursing facilities and other long-term care facilities due to what we know clearly now about the vulnerability of both these settings and the populations that live there, and ultimately reduce financial impact to Oregon's health system. So this particular work is really specific to the governor's earlier executive order that canceled a subset of procedures if they required PPE and were considered non-urgent or elective. So this is not related to broader healthcare services that perhaps have been slowed down or moved to telehealth because of risks, of course, for general transmission. So this particular set of guidances to come are really specific to those procedures that were required to be canceled as part of the governor's executive order. So the framework that we have moved forward and is now posted online state at a high level, these are the requirements that would need to be in place before resuming non-emergent and elective procedures in any facility. So that could be a hospital, an ambulatory surgical center, veterinarian offices or facilities, etc. So broadly speaking, and it depends on what facility you're in as to what the specific criteria are. But generally speaking, we need to ensure that we have adequate and ongoing hospital bed capacity should there be a further surge of COVID-19 patients ahead, adequate PPE supplies following recommended use, access to adequate testing capacity. There's certainly an acknowledgement that testing capacity and PPE supplies are not currently at normal status of open supply, but certainly see improvements in that, and those advising the governor's office and the OHA feel like if certain parameters can be met, it would be appropriate to move forward at this time to ensure healthcare can be returned to Oregonians who need it. Also, facilities need to follow strict infection control policy, and for those such as hospitals and ambulatory surgical centers, they need to continue to follow strict visitation policies as currently exist under the OHA's guidance. Once those criteria have been met, procedures resume. The intention here is to be cautious and to start slowly. We are really focusing on trying to maintain physical distancing, for example, in waiting rooms and patient care areas, where possible between patients and staff, again, where possible, and between staff or members supporting that family or that patient. To really think about, as we're slowly restarting, asking providers or facilities to prioritize those procedures that are most important at this time based on indication and urgency. We as a state are not dictating what that means specifically, but looking to the expertise of healthcare providers to make those judgment calls as we're going to keep slowly ramping up, but what needs to go first is really going to be a requirement just to at least be prioritizing those for who needs it most. There's also some requests in the framework talking about balancing the risks and benefits for individual patients. So if they're at a high risk for COVID-19, how do you balance that risk of bringing them into a hospital or surgical center or a clinic where there could be exposure versus the risk if they further delay that healthcare procedure? And that's going to need to be, of course, as dictated by the health professionals' decision-making with the family and the patient. And also we know there are continued strained resources in addition to testing and PPE. Those could be things like some emerging signs of some pharmaceutical shortages that we've been watching, also transfusions, for example, or of course, if there's a resource needed around a skilled nursing facility that you might consider to continue delaying those procedures at this time as those resources are constrained. So in terms of where we are with moving forward, yesterday the governor issued an executive order, again, that really points to allowing these procedures to move forward. This is language directly from the intro to the executive order, saying Oregon is at the point where it is possible to gradually resume elective and non-urgent procedures as long as those procedures are performed in compliance with the Oregon Health Authority guidance, which will ensure COVID-19 safety and preparedness by maintaining hospital capacity and adequate supply PPE. So those are really our guiding principles in addition to the 5 priorities I shared earlier. So next steps, we are actively working to get guidance published for these different settings and facilities. Certainly they have to be published by May 1st. We are aiming for trying to get those out tomorrow if we can. We know there are a lot of facilities and providers who are anxiously waiting this guidance to allow them to get slowly reopening their procedures as early as Friday. And so more will be forthcoming very quickly here. It's important to note that we as a state and some expectations for hospitals and other facilities will continue to monitor COVID-19 cases, hospitalizations, and of course the surveillance work that Tom already alluded to make sure we're going in the right direction and that we can maintain the resumption of these procedures. We're also asking every facility to be ready to slow down or stop again if need be, if we feel concerned about the way things are moving forward with the impact of COVID-19 as we continue to open up. Please check out the governor's executive order online. The frameworks for restarting are also posted on our website, and very soon the actual formal guidance and the criteria that facilities will need to meet will be posted that will guide us in these future stages of reopening these procedures. All right, I know there will be more questions on that we will respond to. I'm going to pass it off now to Dr. Smits regarding the hospital visitation policy changes.
Thanks, Anna. I just wanted to highlight a couple of things that have changed in our hospital visitation policy. Previously, we had limited visitation to a patient who is actually in the hospital for COVID-19, except for at end of life. We have added pediatric patients and patients with disabilities who might need assistance to that list as well. And then the second change that we made is that in the cases of we had previously said only one essential individual can visit a patient on any given day. We've broadened that just a little bit to say that two essential individuals can visit a patient on any day if they are the parents or guardians of a pediatric patient in the hospital or for patients who are at end of life. And this is just in recognition that these are special groups that might need some special assistance or special needs. And the next thing I just wanted to briefly highlight for you all, and this is just informational, the Infectious Disease Society of the United States has issued new guidelines. There's a link on the slide after this that you'll see in a minute about appropriate PPE use. This may be useful for your practice or your health system. I thought it might be helpful just to kind of point out a couple of highlights from it. So in conventional settings, when there is no shortage of PPE, for non-aerosolized generating procedures, you should use a mask, either a surgical mask or N95, but if for anything aerosol generating, an N95 or better. But if you are in contingency or crisis settings, which the IDSA defines in their in the paper, then you could use a reprocessed N95 or even a face shield with a surgical mask for an aerosolized generating procedure. Next slide, please. And then just as a little aside, they looked at double gloves versus single gloves, as well as foot coverings, and found no information to give you all about that. So if you have any questions about whether whether you should have one glove or two gloves, or whether you should have foot covers, there really isn't any information to give you at this point. And then at the bottom of this slide, you'll see the link to the full IDSA guideline in case you're interested. And then the next thing I just wanted to draw everyone's attention to is the CDC has added symptoms to their definition of what is possibly COVID-19. And just to show you how fast things are changing, I made this slide yesterday, and overnight the CDC has actually updated this a little bit. So this is not a definition of what COVID-19 disease is. It's more for your clinical suspicion when you have a patient coming to see you, what symptoms might make you think to do some COVID-19 testing or consider that as in the differential. So currently what the CDC is saying is that cough or shortness of breath by itself is a symptom of COVID-19, and you should think about that in your evaluation, or at least two of the following symptoms, and it's fever, and then all the ones in red. So chills, shaking chills, muscle pain, headache, sore throat, or new loss of taste or smell. And again, this is just for your clinical thinking when you're evaluating a patient.
Yeah, and we had talked about how this is a fairly sensitive but not specific definition. In other words, if somebody has a fever and chills, they meet the definition with no other symptoms now.
Right, but they may have a completely other disease, and so obviously your clinical decision making would take all that into account. And then as usual, you guys have been sending us clinical care questions. Hopefully we've answered the majority of them in what we've already given you. There were just a couple of others that I thought might be interesting to just give you the answers to. There was questions about whether healthcare workers are having a higher rate or whether there was an outbreak among healthcare workers. Currently, about 18% of cases in the state are healthcare workers, and on our OHA briefing site that Dina had kind of brought attention to at the beginning of this webinar, that data is published every day. So you can take a look and see how many people who are positive have identified as healthcare workers, and that is a broad range of types of jobs. So, and we don't break that down. It's just anyone who works in the sort of the healthcare setting. Then there was a question about virus strains, whether it's different on the West Coast and on the East Coast. And there's actually some really interesting studies that have come out where they've kind of looked at the fingerprint of the viruses, and it looks like the West Coast patients are closer to the Wuhan kind of virus, whereas on the East Coast it's more similar virus to what they see in Italy. However, there's no clinical difference in the disease caused by these strains. It's just more of a epidemiologic kind of interest rather than any real clinical.
Yeah, and the SARS-CoV-2 virus is very stable. So there's certainly always a small mutation rate, and that's how they can trace the different lineages. But in terms of the clinical impact, as you said, Dr. Smits, there's no clinical significance that we can discern in terms of virulence or severity of symptoms.
So please keep your questions coming.
Again, this is your reminder to send us questions. I am realizing that this time I did not remember looking at our inbox, so I'm just going to respond to a couple I see here. We got a question about whether or not wellness visits were acceptable to continue if they don't require PPE. Of course, now concerned about PPE needs when you might be exposed to someone who has some symptoms. As I mentioned earlier, the new executive order allowing us to resume some of those procedures that were canceled previously is not pertinent to, is not addressing at all well child care. Previously, well child care or any wellness visits were not ever required to stop whether or not they required PPE. Those were always allowed at the discretion of a provider or practice. Because they weren't considered within the rubric of the prior executive order. And when we did have an FAQ out there, we said that that wellness visits did not come under that executive order, and they can be continued even if they, of course, require appropriate PPE at the discretion of the healthcare providers. We do realize that there's a lot of confusion out there about what fell under the executive order and what is being resumed specifically as a result of the governor's newest executive order yesterday, and we're looking to get some further guidance on that as well. We know that generally we're going to need to move forward in ensuring access to health care that might have been postponed if it was felt to be non-urgent generally. We also are seeing concerns about drops in vaccine rates, so there's a lot of attention that's needed to make sure that the appropriate healthcare is being received while still taking into consideration reducing transmission, appropriate physical distancing, and the need for PPE to do that. So more information forthcoming.
And just to add one little thing on top of that, immunizations, especially for small children, has always been considered essential. So please continue to immunize, especially for the early set of childhood immunizations.
We will continue to actively look at your questions and make sure we're bringing them up.
Yeah, there's a couple questions that I can answer briefly, I think, just seeing now. Somebody had asked, am I hearing correctly that we hit our surge 2 weeks ago and are on the decline now? And yes, you're hearing correctly. Not sure I would have called it a surge, but we are coming down from our peak in late March. That's what the epi curve is showing. Somebody asked about, well, they mentioned that news outlets have been reporting that Oregon's testing capacity is significantly above the testing that's actually being done. What information can we share with patients? Expressing concerns, frustrations about this. Yeah, so as I kind of mentioned already, we're trying to emphasize that our testing capacity is increasing steadily. We are continuing to revise our recommendations for who can be tested and expand that. At this point, we're not recommending that everybody with symptoms can be tested yet, but we are seeing a significant increase in our daily testing over the past week or two. So we'll continue to broaden that as needed. And then there was a question about testing of asymptomatic people, and I just wanted to clarify our testing guidance, which is pretty open about testing asymptomatic people, but it's not, as was originally reported in one of our headlines, it's not all asymptomatic people that we recommend for testing. It's people in congregate care settings, so people in a group living or a care facility setting. In those situations, people without symptoms may be considered for testing. However, we generally wouldn't recommend screening people, all people without symptoms who are employees or staff, or sorry, employees or residents. It really would come down to who is at high risk. Was there an asymptomatic staff member, for example, who was in one of the units or wings of a long-term care facility where there was a cluster of illness? Then they would probably be near the top of our list. But we don't currently have the capacity to test everybody without symptoms in every congregate care facility right now. So just to clarify that, but we're leaving it open. And again, it's really up to the clinician and their health systems capacity and discretion for who can actually be ordered testing. So I hope that clarifies.
I'll answer two more questions that I got in the email. One, there's definitely a lot of interest and of course for our state as well to be monitoring what the impact is of some of the other states in our country who are having different approaches to reopening or reopening broadly and more quickly. And so we will keep, we're definitely curious, and of course will be important for us to learn what's happening across other states. So as more information is available, we can bring that back to you. We did get some questions about individuals who may die at home or in congregate care settings like nursing homes, and we are now putting some data out there on the website about deaths. We do have deaths by a long-term care facility on our website, should that be of useful information to you. And we also have a variety of different data that we can also bring back specifically in our presentations moving forward. But there is a lot of information now, and if you're interested, certainly please visit our website and we'll try to highlight some of those for you in the future. So before we fully close, we are going to remind you first about tomorrow's Project Echo. We are planning to continue these with OHSU and with Dr. Vines at the Multnomah County Health Public Health Agency through May, and then looking at maybe twice or every other week thereafter, but that will be to come a decision, but for sure we're planning through May, so we hope you continue to join us with that. And then finally, we did want to share some of the hot off the press results of the testing survey that we asked you to complete. We had a total of 90 people complete it. We didn't do a fantastic job of advertising this, so we're glad that 90 people did respond, and it's at least useful, important beginning information for us as we better understand any barriers that folks are facing. So I'm going to pass it back to Dr. Jean to walk us through these slides.
Yeah, thanks. So first, I would preface this by saying that this is, of course, a convenient sample. It's not a representative sample, but we certainly appreciate those of you who took the time to fill it out. And this is, again, the survey I think is still active on our website. It's under the healthcare providers section, and there's a SurveyMonkey link. It's pretty quick. So just ask some basic demographic questions. About half people in the Portland metro area and the other half distributed throughout the state. Not too surprising there. Most people are in an urban setting, and about 23% in rural or frontier.
Oops, sorry.
And then by specialty, 70% primary care and 20% of some other specialty, 7% emergency or urgent care, and then some behavioral health and lab folks as well. In terms of settings, private clinic is the most common setting for people who responded, followed by community health centers, FQHCs, and then hospitals and other. And we haven't had a chance to look at the other responses yet, so I can't really speak to those. So the next question asked about constraints on your providers, your ability as a provider to test. And these were check all that apply, so they total more than 100%. 35% said no constraints, so that's good. And then PPE, well, it looks like other was the number one, but then swabs, lacking access to swabs is actually one of the biggest constraints there, and then lacking PPE, and finally lacking a lab. So this is good information for us to understand.
Do you want to just speak to the swabs and testing supplies we received briefly?
Yeah, we've asked for 150,000 swabs from FEMA. We've received 10,000 so far, and last, I think Friday and Saturday, we distributed 1,000 of those to the state lab, and then the other 9,000 to counties and tribes around the state. The next question is, do you have access to a lab? And I'm encouraged to see that a relatively small portion here said they have no access, although we'd still like that lower. So it looks like Quest, LabCorp, the two major regional/national labs, are pretty well represented. In-house hospital labs, about a third had access to that. OSPHL is listed, that's the state public health lab, pretty low, and that is appropriate given how the majority of testing now is no longer at OSPHL. And then point of care, pretty low there, as would be expected. There's just not a lot of availability of those tests yet, and we'll have to look at the other. And then no surprise in terms of types of testing, PCR, which is the testing that's looking for the virus itself, is that's by and large the type of testing that's happening. We did see, it looks like 10% saying they have been doing some serology testing, and then even fewer doing point of care testing. And so this is showing test type. This is a little confusing, but 2/3 said they don't know exactly what test they're using. And then we have a bunch of different ones here. So the Cepheid and the BioFire, or sorry, the Abbott would be the kind of cartridge rapid-based PCR tests. LabCorp and Quest, of course, we know are doing some of the major PCR types of testing. I guess 19% said not applicable. I'm not sure what that would be. They're not testing maybe, or they don't know. And there's a few other names there I'll have to look into.
Great.
And then the final question is guidance a constraint on your ability to test, check all that apply? So about half said it wasn't a constraint. About 20%, a little over 20% said the OHA guidance is too restrictive. And then about the same said their organizational guidance was too restrictive. And then a fewer said that CDC guidance was restrictive. And again, I would remind people that the OHA guidance really is not restrictive. It's, it depends on how your health system or your clinic or facility is choosing to use it, but it's not intended to restrict you or allow testing. It's really to provide guidance, and then again, it's up to you to decide who you can actually order a test on, subject to what's available and what your clinical concern and other risk factors are. So just drive that point home one more time. So thanks again for everybody for completing the survey. We appreciate it. And if you are watching right now and you haven't completed the survey, feel free to hop on our healthcare providers website, healthoregon.org/coronavirushcp, and scroll down to the healthcare providers section. And I think it might be a blue button down there that says survey, provider survey.
Great. Well, thanks for bringing to our quick add-on at the end of our slideshow. We hope this information was useful, certainly to all of you, and interesting. It certainly will be useful to us. Again, a reminder, tomorrow or Thursday is our next Project Echo session. We'll continue these all weekly through May. Please send us your questions or topics that you'd like us to cover, either again through these chat boxes or through our healthcare provider email address that we have on these slideshows. And we look forward to being back with you on Thursday. Thank you, everyone.